Good afternoon, everybody, and welcome yet again to another Samaritans Purse International Health Forum. I'd like to welcome you today and really just encourage you to join in our conversation. As always, to the right of your screen, there's a chat box, which we'll predominantly dedicate to Q&A at the end of our talk today. But before we get started, I'd just like to open us up in a word of prayer. So let's bow our heads. Dear Heavenly Father, we just thank you for this beautiful fall day, and we just thank you for this opportunity to just have dialogue, Lord, with one another, and to learn more about medicine, disaster response, and how we can serve the world, Lord, just through the opportunities of medicine. Just speak through Dr. Kelly today, and we thank you in Jesus' name. Amen. Well, I'm delighted to have you all with us today and delighted to introduce our speaker and good friend, Dr. Aaron Kelly. Dr. Kelly is an emergency medicine physician, and he's fellowship trained in disaster management and emergency response. Currently, Dr. Kelly is an attending physician for Lehigh Valley Health Network in Pennsylvania. Prior to that, Dr. Kelly and his family spent 2.5 years serving as medical missionaries in Tenwek Hospital in Bomet, Kenya, where he helped oversee the casualty department. He served as the internship director and helped develop a disaster management committee. So I'm delighted to introduce Dr. Kelly to you today as he presents disaster response preparedness on the mission field. Dr. Kelly, I'll turn it over to you.
All right. Thank you so much, Lance. I really appreciate it.
Absolutely.
So yeah, we'll go ahead and we'll get started. So just as a quick disclaimer, I am certainly not the expert in disaster response preparedness. I do have some experience with it. So just want to kind of put that out there. This is kind of speaking from my experience, not as an expert, but as someone who's been through at least a little bit of the preparedness aspect. This is also not going to be dealing with an primarily outside to inside response. So basically, Samaritans Purse is great about responding to disasters. You know, they come in to wherever the disaster location is and respond. This is not a talk kind of framed in that way. This is more geared towards being on the mission field and preparing internally for some type of disaster response. So with that, we'll go ahead and we'll start with a couple objectives. So the first is just to give a brief background of myself. So we'll just go through a little bit about my background, my training. We're going to look very briefly at the importance of team building and how that can play into getting prepared for disaster. And then really going to spend the majority of the time looking at some of the disaster preparedness experiences that I had during my time at Tenwek Hospital. And then we'll complete by just looking at some of the potential pitfalls that can occur during these attempts at preparation. So just starting with a little bit about me, my background. I did a rotating internship followed by a 3-year residency in emergency medicine. That was followed by an EMS fellowship, which kind of had multiple facets to it. There was a little bit of tactical medicine, some wilderness medicine, did some aeromedical transports and flight medicine. But the primary focus of my training was dedicated to a disaster management and emergency preparedness master's program that I did in conjunction with the fellowship. After completing my fellowship training, I stayed on at Lehigh Valley Health Network for several months prior to us packing up and then relocating to Tenwek Hospital in Bomet, Kenya. As Lance had mentioned, we were there for about 2.5 years. For those of you who are a little bit geographically challenged like I was, as far as what is in Africa and where all the different countries are within the continent, Kenya is located on the eastern border. We're just south of Ethiopia and also share a border with Somalia. Bomet is located about 4 hours northwest of Nairobi. It's a very rural location. As you drive out there, you're surrounded by, it's really just beautiful scenery. It's mostly tea fields, just a lot of agriculture in that location. And as far as disaster response preparation, there's very few resources. There's very little there to tap into externally in that surrounding area as far as a disaster response is concerned. Tenwek Hospital itself is really kind of a unique hospital, despite the fact that it is quite rural. It's a 300-bed inpatient facility. Multiple specialties are represented. We have medical team, we have pediatrics, general surgery, orthopedics, OB. At any given time, we have multiple visitors. I know there's an SP post-resident there now who's a neurosurgeon. So right now they're offering pretty consistent neurosurgical services. So despite the fact that it is so far removed from kind of the main locations in cities, there really are quite a few services that can be offered to the surrounding community. Being ER trained, I was primarily stationed in what they call casualty. That is their form of the ER. It's also called in parts of the country accident and emergency. Really, it's a very small unit that we have. It's only 7 beds. It is literally one room. It used to be the hospital lab, so it's not necessarily well laid out for an emergency department type setting. It's actually located centrally within the hospital, which you can imagine creates a few issues. Most ERs throughout the United States and throughout the world are located at the front of the hospital for obvious reasons. Whenever you have people that are very sick or gravely injured, you don't want to be transporting them, long distances to a treatment location. It's about 100 yards, give or take, from the front of our hospital back to the casualty department. So again, you can imagine that does create a few issues. Whenever I arrived, did not have a whole lot of top-of-the-line equipment. We had 2 partially functioning monitors. We had 1 pulse ox machine that was transported from our department up to triage back and forth, would go missing fairly frequently. Whenever I arrived, we also had 1 EKG machine. It worked most of the time, but was not fully consistent in that. And then there were it seemed like countless drawers and cupboards just full of random supplies. So whenever you look at this next picture of my department, in full disclosure, this was not taken right after I had arrived. This was actually several months after we had started implementing some changes. So while it looks somewhat chaotic, it actually is much better organized than it was whenever I first walked through the doors. And moving on to the next picture, you can see countertop. Again, this looks like it's pure chaos. This is actually somewhat organized compared to how things were whenever I had first arrived. But this just kind of shows that even as we were going through and starting to organize the department as a whole, it was really an ongoing process. It was by no means a once and done. Whenever I had been preparing to head to Tenwick, really had never been on the mission field full time, had gone on several short-term trips. And so, we went to several different types of training, some through Samaritans Purse, some through CMDA, really tried to engage veteran missionaries as much as possible, and received this one piece of advice from one of them that really it's what I went back to over and over again. He said that it's really important whenever you arrive on the field to wait at least 6 months before trying to implement any significant changes. And it seemed like that would be kind of an easy thing to do up front, at least. But really, once I got in the field, it was very difficult. You go in and you see, just seemingly countless things that should be changed. And why don't you do this? Why are you doing that? And so really felt like I just wanted to hide my head, just wanted to bury my head and act like, what I was seeing wasn't there. It was fairly difficult to just sit back and not immediately engage and try to implement as many changes as possible. So moving on, laying some of the groundwork then for some of the changes, really it seemed important to start small. That again, it seemed like there was an endless supply of things that could be done or should be done, but it was really overwhelming to even think about starting to implement any meaningful changes that would be sustainable. So kind of started looking around for something small just to make a small change and kind of gain a little bit of traction. During this waiting period, it was also a time to develop a team. Kind of took a step back, tried to figure out, kind of the roles of the different people in the department. Tried to find some people that could really take ownership and be champions for any long-lasting changes, and was able to do so fairly effectively. The first project that we really took on is what you see pictured here. It's our airway baskets. So I just want to very briefly tell you about 2 different cases I had. One occurred within maybe the first couple weeks of me arriving at Tenwick. We had a patient that came in severe respiratory failure, was probably in his 60s, and had a very severe case of pneumonia. Obviously needed to be intubated. And as we went around to the various cupboards and cabinets that had supplies to collect everything to manage his airway, from the time we started until we actually secured the airway was probably about a 20 to 30 minute event, which obviously, if you have someone that is in respiratory distress, is far from ideal. But it was very difficult to find. We had to get the ET tube, we had to get the stylet. The stylets were missing. Had to find an appropriate bag valve mask, find suctioning equipment. It was just a very long and drawn out process. And during that time, of course, the patient is suffering, and hopefully not. We didn't cause any harm by the delay, but we certainly weren't doing that patient any favors. So where I had trained, we had carts kind of for everything. We had an airway cart that could be wheeled to the bedside of a critical patient, which would have all the necessary supplies. And so thought about, well, what can we do in this setting? Well, we're not going to get an airway cart. We're not going to have all that type of advanced equipment, but we could do a basket. So actually on one of our trips to Nairobi, we bought several picnic baskets, which is what you see in this picture. They're available at the local Nakamot, their version of a Walmart, for just a few bucks. So we bought, I believe, 5 or 6 of those and actually outfitted them so that pretty much everything we would need would be right there. We had 4 set up for adults, 1 set up for pediatrics. We put a list on there, kind of a checklist so that people could restock these. And then we actually took the laryngoscope set, put it in a locked cabinet where it also became placed on a checklist just to make sure that it was functioning and all the component parts were there at the beginning of every shift. Very shortly after we had implemented these changes, we actually had another patient come in respiratory failure. This time it was someone in their 50s, very florid pulmonary edema from congestive heart failure. And from start to finish, we had secured the airway in less than 5 minutes. It just kind of outlined, especially to the staff who was kind of new to some of this preparedness talk, the importance of organization, the importance of being ready for what may occur. And it helped to give a little bit of traction to some of the things that I had talked about with them. If we could just go to the next slide. These are some of the important people that were on my team. To my left and to my right is Zeddy and Nelson. They were both emergency trained nurses. So they went through their regular training, and then each of them were able to go to Nairobi for an extra year of training on top of that. So these two very quickly became identified as leaders in the department, became very close to them, and they both were members then of the Disaster Preparedness Committee, and were very key in implementing a lot of the changes that we made both internally and throughout the hospital as a whole. If we go to our next slide, this again is taken after quite a bit of work had already been done. I had mentioned earlier about the cabinets just being full to overflowing of various supplies. As I went through the supplies, probably the most common theme was that they were either completely non-functional, they were missing component parts so they couldn't work, or it was stuff that was just simply expired, and so far expired that it was actually degrading. Obviously, this is not ideal when you're searching for something that you can use, to just have that intermixed with supplies that are not safe. So we started a process of going through the entire department, basically clearing everything out. We emptied every cupboard, we emptied every cabinet, every box, and we went through each supply one at a time just to figure out what was actually functional, what we could use. As we were doing this, we cleared out cabinets that just were kind of in the way. Whenever I had first arrived, there was actually an MCI box that stood about 4.5 feet tall. It was painted red, so it was very obvious. But whenever I started going through the MCI supplies, as they were noted, just didn't make sense for a mass casualty event at all. This was supposed to be the box that could be wheeled to whatever location to handle an event. I've responded to several mass casualty events, and I can't recall needing a Foley catheter in the immediate stages of a mass casualty event. And this thing had dozens and dozens of Foley catheters of every size, and configuration you could imagine. And that's just one example of the type of stuff that was in there. So we actually got rid of all those supplies. We got rid of the box as a whole and just reorganized really the entire department. Now, if we can move on to the next slide, this will show once we had started implementing some of these changes, what it looked like. So all the cabinets became labeled. We laminated labels and stuck them on there so people could know exactly what we had and where it was located. We then put locks actually on all the cabinets. Casualty being centrally located became a very easy place to go to just snag whatever was needed. And we found that various people, some not even staff members, were getting into some of the cabinets and taking supplies. So we had to secure those as well. But just tried to get everything organized throughout the entire department in a way that made it a little bit more efficient and a lot more effective in providing good patient care. If we can go to the next slide, it'll show our medication cupboard. Same type of thing there. We went through, cleared everything out, figured out what was still usable, what was expired, and then organized it in a way that, I mean, it doesn't look like it's the most effective method, but in this setting, it actually was highly effective, was able to be maintained and made it easy to kind of keep a constant catalog of what we had and what we didn't. The next slide will show just an example of one of the drawers. This was just our wound repair drawer. So just taking supplies for one type of injury, some lacerations in this example, putting the bandages, the sutures, you know, the numbing agents, the skin cleansing agents, just putting it all in one location really was not done at all for the most part whenever I arrived. And so we just tried to go through and organize everything in a way that made it much easier to respond, not just whenever there was a large event, but even just for small events. You know, if we had a patient or two come in, you weren't wasting, you know, who knows how much time trying to collect supplies from around the department. In mentioning the champions, Zeddy and Nelson specifically, they really took charge of all this, which was really fantastic. I had a lot on my plate. I could not continually be kind of staying on staff for keeping things organized, making things were supplied appropriately. And so they on their own developed a checklist for the department to make sure that we had adequate supplies, that everything was accounted for, that as things were coming in and going out, that everything was being documented appropriately. And they were the ones that really took ownership over it. You know, if I saw they were having an issue, I'd just go to them and they would then track down whoever they had to get it rectified, which really took a lot off of my shoulders and really helped us as a group, core group of people in casualty to develop some good camaraderie, good teamwork, good friendships as well. Another project that we took on was then for our ambulances. Tenwick has 2 ambulances. As you can see from the photos, they're quite old. They're not in the best condition. Whenever we went out to the ambulances to look and see what was there, again, most of the supplies that were there were not usable. They were degraded, they were broken. And actually looking in a couple of cupboards that are in there, you open up one of them and you could actually see down through the floor to the ground. So obviously maintaining supplies in that type of environment would be difficult at best and most likely would be impossible. So we kind of took a step back to figure out how could we outfit these ambulances appropriately but not be just wasting money as supplies are being ruined from being stored improperly. And just to take a step back, so ambulances, as we think of them in the United States, is not really how our ambulance over there ran. They didn't do scene calls. They didn't go out to the location of an accident. Basically, these ambulances are used as transport vehicles. So if we had someone at our facility that needed to be referred out somewhere else for a higher level of care, we would take these ambulances. They would basically just grab a handful of whatever supplies they thought they might need, and they would take those with them during that patient transport. So what we ended up doing was we found a financial backer here in the United States, and we actually bought some jump bags, which you can see in the next slide. The jump bags, we had several of them. We had an airway bag, we had a trauma bag, we had an IV start kit, medication bag, and then kind of the bag for everything that wouldn't fit in the other bags, such as C-collars and splinting supplies and things like that. Again, checklists were made so that an inventory could be kept. And if we were going to be transporting a patient, these bags were kept in the nursing supervisor's office. They could grab these bags, take them with, and certainly have everything that they would need for that transport of that patient. So this was just another one of those projects. It wasn't a huge project. That being said, it still took months and months to fully implement. Even these small projects can take quite a bit of time in that type of setting. But this was, again, something that helped us to gain some traction, gain some credibility among staff members, and especially with hospital administration. Whenever they saw, some of the simple, small things that could be done, gave a little bit more credibility to what us as a committee then presented to them later on. So now moving on to the preparations we made. So whenever I arrived at Tenwick, there was a disaster committee there. They met fairly infrequently. They had a disaster manual of sorts that was already there, although it needed a vast amount of revision. So what we started doing is we started just line by line. We started going through this disaster manual and trying to figure out what would work, what wouldn't. Trying to bring in some of the knowledge and experience I had from my training stateside, and then trying to figure out why some of the other plans that they had tried before had failed. That was really a key part of the waiting, was taking a step back and figuring out, what had been tried before. Was it just implemented incorrectly? Was there an actual issue with the way it was implemented, or was it just a bad idea to begin with? Was there some reason within the hospital or the culture itself that the other plans had failed? And so it really was a very good collaborative team effort, by myself, by some other key players, and by the committee as a whole, which represented everything from pastoral care to security to nursing from various departments, just trying to bring everyone together to figure out how we could revise this manual and devise plans that would be effective, that would allow us to do the most good for as many people as possible in the event of a mass casualty event. Once we had gone through and had completed the manual, then it was time for a lot of education to take place. Initially, that education was just within the committee itself, and that actually kind of went in conjunction with revising the manual, just kind of bringing some educational points as we went through and we're trying to revise it. But then we kind of spread that out. And this wasn't just me going around providing the education. I made it very clear to the committee that while I was a member of the committee, I was not the only person on the committee. And so each of the committee members was responsible for providing education to various departments, whether that be a specific department of the hospital or security, pastoral care. We even made sure that we provided education to hospital leadership, to senior management of the hospital. Provided a opportunity for them to be educated on the disaster manual and the implementation of it. Once we had gone through and done a lot of education, we took another step back and actually looked at the hospital as a whole. Went through and did a full hazard and vulnerability assessment, really looking at the 4 key categories that are important in doing so, looking at natural disasters, looking at technological disasters, looking at human hazards as well as hazmat hazards, and broke all those down and then looked individually at the subcategories to figure out where Tenwick was most vulnerable, what the biggest risks were facing us as a hospital. If we can move on to the next slide, it just is a screenshot of our disaster manual. This was probably the 12th revision. And again, like most documents, it's never fully complete. With every event, with additional trainings, it will continue to be revised, but this was the most recent revision at the time of my departure from Tenwick. And then moving on, as we did the education, it became very apparent that we really had to take it down to the most basic level in a lot of ways. Disaster preparedness for the committee was not a huge stretch, as they had at least had some inkling of what it was about, and how it worked, and what the moving forward might look like. But whenever we tried to start rolling this out to other hospital staff members, a lot of them had no idea They had no encounter with mass casualty events, response preparations in the past. And so just starting with some very basic definitions is kind of what we did. Presented them this plan as an outline to a scalable emergency response system. And the scalability was really one of the most important concepts because obviously if you've got an event with 5 or 6 people, well, depending on the situation, it could be designated as a mass casualty event, depending on the baseline status of the hospital at that point. But certainly you're not going to mobilize and activate everyone like you would if, say, you had 40 or 50 victims. And so it was very important that this plan could be scalable, could be scaled up, could be scaled back to provide appropriate care to the number of victims that were coming in from whatever the event was. Next slide basically just gave the definition of what a mass casualty incident was. We kind of adapted it a little bit to be Tenwek specific, just to make it a little bit more real for them. And our definition was as follows. It was any number of patients that arrived at Tenwek in a fairly short period of time, which overwhelmed our systems. And really that's a very generic kind of definition, but it is a very clear definition. Really an MCI, people think of it as being a large volume of patients, but if you have a hospital that's already running at 100% capacity, honestly, a car accident bringing in just 5 or 6 victims is in a sense a mass casualty event. And through that, we need to figure out how we can best respond to care for not only those victims, but the victims, the patients that we already have in the hospital. The baseline goal of mass casualty incident response is to provide the greatest good to the largest number of patients possible, which also is a little bit different from kind of the baseline thinking in medical care. Typically, we want to provide the greatest good to everyone. That's what we do. We want to help everyone. We want to do the most we can for every patient. But in a mass casualty incident, that's not always possible. And so our goal is to do the most good we can for the largest number of people. And that means having to do triage a little bit differently. It means approaching patient care a little bit differently. But it was very important in this setting for them to understand what our ultimate goal was as we went through these preparations. Now, if we can go to the next slide. This is going to be showing just one of the component parts of our hazard and vulnerability assessment. This was looking at the human hazards. Again, we went through those 4 categories and then broke it down into subcategories. And as we went through and listed the risk of each, the probability of each, basically it computed out then and gave us that a mass casualty incident was our greatest risk. And really it kind of tied out with a mass casualty event that was trauma and one that was a medical or an infectious etiology as well. So that's really what we primarily focused on. That's what the disaster manual was primarily tailored towards, was a mass casualty event that was either traumatic or medical in nature. And that's really what our initial trainings were geared towards as well. Next slide shows just one example of why an MCI of a traumatic nature is so typical in Kenya. Motorbikes are everywhere. They serve as taxis, they serve as transport vehicles for supplies, believe it or not, for livestock. And I'm not talking about just chickens in a crate. I have seen goats being hauled side by side on the back of a motorbike. I've seen furniture, I've seen full armoires on the back of motorbikes. And for those of you who have traveled internationally, you know that the road systems are not so smooth all the time. So you combine questionable roads with questionable transport practices, on top of the fact that inspections for the vehicles are not always the same standards as what they are in other countries. And you can have a setup for disaster. One motorcycle accident can bring in, in this case, 8 victims. And we see that very, very frequently. Prior to my arrival at Tenwek, several years beforehand, there had been a massive bus accident that unfortunately many, many people died from their injuries from this accident. So despite the fact that Tenwek is fairly rural, we very frequently get victims from fairly large-scale accidents. So as we moved on from the basic education, we then went on to tabletop drills. We went through 9 wards throughout the hospital. We had 6 scenarios that were written up, each scenario tailored towards specific wards to try to stress them and place as much strain on that department as possible. As we went through these, we then compiled after-action reports, gave some real-time feedback to those people, and then also compiled these reports that we could go back later after we had gone through all the wards and provide overall feedback for everyone. Identified quite a few weaknesses. Some were actually issues with our plan. We were able to see things from different perspectives as we went around to these other departments, as we figured out some issues that they had that we never would have thought of. So we went back and again revised our manual a couple more times. There were some issues with people not really understanding implementation. Triage became an issue in some departments, figuring out how to triage, figuring out how to do reverse triage to make more space in each ward. Reverse triage was a relatively new concept, so additional education had to be provided for how to go through that process. So just a whole lot more education based on what we learned from doing these tabletop drills. The next slide is going to show our triage tags. So we opted to go with the START and the jump start triage methods. These are fairly fairly trusted methodologies for triage. They're relatively simple, easily repeatable. It's been around since the early 1980s. Actually originated out in California. I believe it was a Newport Beach Fire Department had initially come up with these methods. And so we took that and we kind of tailored it to make it a little bit more Tenwek specific. So you can see on these cards, we had the triage tag number. We actually would have to handwrite in beforehand what the triage tag number was. We had a place then to put the hospital identification number so that we could then correlate this tag with the hospital record. A little section for some demographics, very brief, past medical history, if that was applicable. And then we actually had the triage algorithm printed directly on the tag so that they didn't have to memorize it, so they didn't have to refer to another sheet of paper. They could actually just go down through the flow diagram and figure out the color coding for each victim. The bottom part of the card, we actually had these printed at a location not too far from Tenwek, and then actually got a special perforator that we could go through and perforate between each of the color codes that you could then tear off whatever the color code was to identify that victim. So it made it very easy to identify even from a distance. And then the back part was basically a physical exam and ongoing care location. So just a very quick little diagram that you could quickly put on there if there was, laceration, an amputation, whatever the case may be. A section for lung sounds, just for a quick assessment of lung sounds. Try to rule out, if there's a pneumothorax, hemothorax, something along those lines. Had a section if a fast exam or later on an X-ray happened to be done, what that showed, and then a location for ongoing vital signs. You don't want to have just the first set and then leave the victim and not come back and reassess them. So we tried to encourage reassessment of victims, not just an initial assessment and let them sit in the corner. Also included a very small section for what interventions happen to be done. And then as we move on for the actual hospital drill, it was kind of interesting. So what we ended up doing was we actually engaged the local boys boarding school, which is located just up the street from our hospital. So we went up there and talked to the principal and to some of the leaders, and were able to have about 45 mock patients that were these students. We went up there, we did some educational time with them, kind of explained what was going to happen, and actually had 45 individualized scenarios. So they each got to act out a specific case. They knew what their injuries were. We had already prefabricated what their injuries were going to be, what their vital signs were going to be, and just kind of taught these kids how to act out, what a broken arm may be like, or what, internal bleeding may look like for them. We tried to simulate fake injuries. We didn't have access to anything high tech. We didn't have access to fake blood, so we developed a fake blood out of a ketchup that we could buy in bulk and kind of boiled it down a little bit. We developed some other fake injuries using Sharpies, could simulate abrasions and contusions, various forms of ecchymosis. So just really engaged them and utilized them as a resource for the hospital. The next slide shows that as we were having this initial response, we utilized our hospital ambulances. We used both ambulances. We also used some privately operated vehicles. And we tried to simulate the way that patients would most likely show up in a real event. It's not always the sickest patients arriving first. Most often you have some of the green victims, the walking wounded, or the involved but not injured victims that arrive. They jump in private vehicles and they show up usually first. And then you get wave after wave of victims after that. And so we tried to simulate that with the way we brought patients into the hospital. The next slide shows how triage was occurring. So basically the victims were all dropped off at the very front of the hospital at the hospital entrance. They were then from there taken to the appropriately designated areas based on their triage tag color. As you look at the next slide, it shows what casualty looked like at one point in time. Really all the departments struggled with the principle of reverse triage. It was very chaotic, which is very much normal for a mass casualty event. We had vests to designate people in leadership positions in each department so that they could be identified very easily from a distance. And as each department was filled very quickly, the stress levels were increasing as they were stretched well beyond their capabilities. Next slide, just as another example within casualty of how busy things looked. Even movement within a department became an issue. Like I had mentioned, casualty is one room. It has an entrance and an exit that are located in very close proximity. So it became a little bit difficult even to maneuver within the department, which again added more stress. The next slide is showing the mock press conference that we had. In addition to having all of our victims, we also had individuals from the school that acted as police, as media, as family members, trying to simulate in as many ways the way that a response really would occur. You're not going to just be dealing with victims. You have to deal with their families. You have to deal with police presence. You have to deal with just a lot of different aspects in addition to just the straight up medical care. So we simulated a press briefing that hospital administration had to handle. And then we had to deal with all these different family members, some of which, they were given specific roles that, you were supposed to be distraught, you're supposed to be hysterical, or, just various ways that people respond whenever their family members are involved in this type of incident. The next slide just shows one of the victims. We stressed even our morgue. We took them to well beyond capacity, and so they had to find a secondary location to store the simulated bodies. They followed the plan and utilized one of the clinics on our hospital property. And along with that, then, the family members and trying to identify who went where and what happened in terms of that. That was also part of the disaster drill. Once all this was completed, we then moved on and compiled an overall after-action report. The core team from the Disaster Preparation Committee all served as evaluators during the drill. Everyone was taking notes and evaluating, and honestly, they were pretty hard on each other. They were able to identify weaknesses and identify issues pretty effectively. And from that, we compiled an overall after-action report that was then delivered to hospital administration. In total, with our simulated patients, all the students, the staff members, the interns, the residents, everyone in total, we had about 150 to 175 participants, which was quite an undertaking. But when it was all said and done, there was quite a sense of accomplishment. In fact, we ended up then going for a round 2. This was done several months prior to my leaving on furlough. And before I left, they wanted to go through this again. They wanted to prove that they had made changes, that they could do better. And so we actually had another mass casualty event. This time it was a simulated political rally taking place in Tenwick. And after the first event, we actually had the Red Cross, the local Red Cross chapter wanted to be involved. So we staged this up at the school. and actually allowed them to participate as well. They only gave us one unit, but we allowed them to come and stage at the site. They were able to then do an initial triage, help transport victims down. And while it wasn't perfect, you could actually see quite a bit of improvement from our first round. So just moving on to the next slide. As far as advice I would give, the very first thing I would say is it's complicated. It is incredibly complicated. You've got local culture, you've got local hospital issues, you've got issues within just the general vicinity, trying to collaborate. You've got governmental issues. There's a lot. There's a whole lot, and it is complicated. And from that, I would say you have to wait, and then wait some more, and then wait some more. That advice that I had received prior to going to Tenwick was probably some of the most important advice I could have received. And again, the waiting is not sitting there doing nothing. The waiting is just kind of gauging the terrain, figuring out exactly, what has gone on, what the good, the bad, what's been tried, why it failed. And another part of the waiting is finding and developing champions, developing that team. You don't want to try to go in and do it your own. You can't be the Wazungu, the white guy going in, trying to make all the changes on your own. You need to have a team. You need to engage them. They know the culture. They know the location far better than you do, and they probably have a lot of answers. In addition to that, I would say that you want to start small. The airway basket was my example. Just those little projects that are relatively easy to accomplish, to kind of gain some traction, as it were, and then to move on from there. Another very important thing is to include hospital or clinic leadership. You can't go in and make these changes and be oblivious to the fact that you are serving underneath hospital leadership. It was very important for our committee from the beginning to include someone from hospital leadership, to maintain close connections and close communication with them, because it's their hospital. They want it to succeed. They want to do well. They want to serve their people as well. So to exclude them would be to do a huge disservice to any preparation that you could be doing. And also, I would say engage the community. The opportunity to work with those students was actually fantastic. And at the conclusion, we actually were hearing back from a lot of them that some of them were now considering careers in medicine, either as nurses or physicians, or some form of medical training. A lot of them hadn't seen or had exposure to medicine in this type of format, and we're very excited to see the difference they could make. And this is just a relatively small thing that we did, but engaging the community, they're the ones we're serving, so engaging them is also key. And probably one of the more difficult things would be to develop a culture of disaster preparedness. And I'll be honest, I don't have the answers on how to do that. That is a very tough thing to do, to step into a very foreign culture and to try to make changes in a way that allows for disaster preparedness. I feel like we did a reasonable job of that at Tenwick. I feel like we started small and worked up and engaged correctly, but it definitely was not easy. And just to close up with a few potential issues. So there's no two locations, there's no two cultures, there's no two projects that are the same. So what worked for me at Tenwick may not work in most other places. I think some of the guiding principles would be the same, but just keep in mind that it's not a copy and paste. You can't just carbon copy and have it be successful elsewhere. And keep in mind that it is incredibly hard to prepare for a potential event that may or may not occur whenever day-to-day operations are a struggle. At an individual level, that can just be, some people struggle to put food on the table. So it's hard to think about planning ahead. From an institutional standpoint, it's really hard if you're struggling to make ends meet and to make sure your employees are paid, to think about diverting funds for an event that may or may not occur. So it's important just to keep that in mind. And I think it's also important just to expect a lot of obstacles, because while funding is definitely an issue, it's usually not the only one. Personnel issues can arise, people who are willing and able to be engaged, education and training. This is not typical stuff that is given in medical education overseas, so that can be a challenge. Cultural differences, we could talk for hours just about how that could play in. That is incredibly complex, incredibly difficult. So just going in, expecting that can make a world of difference. And then upkeep, and that goes for equipment, for training, for all the above. It's not just a once and done implementation and you can run with it. There is need for ongoing upkeep with all of that. And just from there, I guess we'll move on to if anyone has any questions.
Okay. Well, Aaron, let me start by saying, wow, that was incredible presentation. Dr. Bruce Steffi says, commendable work at Tenwick, and I certainly concur with him. I'm not trying to swell your head, but honestly, that's one of the better talks I've heard on disaster preparedness. And I think you're right, Aaron. It can be very, very complicated. But I think if you break it down like you did, it's all about organization, and it's all about preparation. It's all about being ready, as you commendably did with Tenwick, and providing that education, developing those simulations and creating that culture, which I think you've done. And you started very simple and went from there. So, yeah, we need you on the DART team.
Sounds good.
Yeah. So as I stated in the beginning of our presentation, there's the chat box there, and I really encourage you this is your opportunity to pose questions to Dr. Kelly. Let me just start off, Aaron. It's already Dr. Steffi stated, would we be able to share your forms from your presentation with the viewers? With your permission, we can certainly do that and make that available via our Samaritans Purse International Health Forum email list.
Yeah, absolutely.
Okay, awesome. Yeah, and one of the things while we're waiting for questions, one of the things I'd just like to say is, again, I think have done an incredibly commendable job preparing Tenwick, and that's actually one of our new objectives at World Med. Is we really want to foster that environment, that culture that you're talking about, and really working with our various partnership hospitals to help empower them to be prepared for disaster response. So, Aaron, you can that may be a way that we can get you more involved in the future, because you certainly have a good grasp of what it takes.
Absolutely.
Yeah. So I do have a question. It says from TK Dirks. It says, any suggestions, gear recommendations for responding for EMS providers? Any particular gear that you particularly like, Aaron?
I think it's really easy to go all gung-ho and get the best of everything and to be so weighed down. I think honestly the best thing is to keep it simple. I've done some talks on wilderness medicine, and sometimes a roll of duct tape, some safety pins. You can go a long ways with that type of stuff.
Right.
You want to be able to be mobile. I guess depends on the situation. You don't want to weigh yourself down with a bunch of supplies, and you have to keep in mind that while you could do a lot up front, that may not be what's best. It may not be what's sustainable. So you're not going to take, for example, a lot of airway equipment. You're not going to be able to maintain, unless you're responding just to a single victim. You won't be able to do adequate job of maintaining an airway if you take a bunch of airway equipment. So really just kind of keeping it simple, some stuff for dealing with, tourniquets, maybe some simple splinting material, but really just kind of keeping it very basic, at least depending on the situation, where you're responding to and exactly what you're referring to.
Awesome. All right. Well, thank you. Yeah, I know. I certainly concur. I think you can get bogged down with a lot of technologies that may not add a lot to your response capabilities. So thank you. Yeah. Any other questions from the audience? While they're doing that, I was just going to ask you, Aaron, from your own educational experience, do you have any like favorite literature or like websites or any information like courses that you would recommend our listening audience to utilize in preparation for disaster response, especially with regard maybe to developing world situations like Tenwick?
I think I just kind of used a combination of what I did as I went through my training. So there's a lot of free literature out there. Mm-hmm. You can just Google and find a lot of information at this point. As far as courses, I mean, I'd done a tactical combat casualty care course with the military, had gone out to Vegas and done that. That actually provided quite a bit of insight as far as just how to respond and deal with the bare minimum up front and then get to a safe location. Obviously, it's a little bit different setting in the mission field, but some of the same principles apply. So there's not any one go-to I have, but there is a lot out there. There's a lot of good information. You just have to kind of look around for it a little bit.
Great. All right. Well, thank you. And I'll take this opportunity to put in a little advertisement and plug for our disaster assistance response team here at Samaritans Purse. We offer it's just a 3-day course with a lot of just some of the basics that that Aaron just went over. So if you have never taken a look at that, I encourage you to look at our Samaritans Purse website. And if that does interest you, you can apply to participate in that preliminary or that DART course and be a member of our disaster response team. Like I said, a lot of what Dr. Kelly presented today, we certainly are in alliance with many of the core principles that he talked about. So, Dr. Kelly, I thought we would have a whole slew of questions from our audience, but right now that we don't have any other ones, but I'm going to just make a few advertisements while I'm waiting potentially for a few other questions before we adjourn for the day. But just want to remind everybody that there is CME credit available for this session. The form and instructions are in your email, and we will be sending a follow-up email with the link for this recording. If you're not on our email list, you can join us at health.samaritanspurse.org, and you can be the first to know about upcoming events. And with that, I'm also just going to share one other thing. I'm sure many of you all have seen in the news that there's just been disaster after disaster, both domestically and abroad. Right now, with Hurricane Harvey and Irma, Samaritan's Purse is deployed to Texas, Florida, and now the Caribbean as well. So that's really a combination of our domestic and international teams. And then there's quite a bit going on right now in Myanmar and Bangladesh with the ongoing persecution of the Rohingya Muslim people. So please be praying about that as Samaritan's Purse is looking for ways that we can respond to that disaster and partner with our partnership hospital, Memorial Christian Hospital, which is in Bangladesh, is seeing a lot of the casualty currently. So be praying about that. Next month, going back to the forum, we will be meeting again on Wednesday, October the 11th. Dr. Richard Lane from Liberty University, who we partner with quite often. He will be speaking. Subject is to be determined. So please set your put that on your calendar for Wednesday, October the 11th at 12 Eastern Standard Time. So, Aaron, I don't see any other questions. I just want to say on behalf of Samaritan's Purse International Health Forum, thank you so much for an incredible presentation. And God bless you and your family.
All right. Thank you so much. Appreciate the time.
Okay. Thank you all. That's it for the forum. We'll see you next time. God bless.